Very much for that introduction, and I realize I'm sort of standing between you and lunch, so I'll try to do this quickly with less time on the clock than I thought I was going to be given. So here are the learning objectives. You can read them yourself. And I want to make a comment about personalized medicine before we sort of get very much further, and that's that personalized medicine, you've heard a lot about omics of various kinds, genomics and other omics. And personalized medicine for me is a doctor taking care of a patient. And this is a quote from William Osler that I'm pleased to use in many contexts because it says what I think is important about personalized medicine, and it also comes from a Canadian, and I'm Canadian. So the good physician treats the disease, the great physician treats the patient with the disease. And that's what we want to do. We want to improve care of individual patients. One of the visions that we have is this, is embodied in this cartoon. And it came out when the first draft of the human genome was announced. And this woman has her genome sequence on a piece of paper. That's not the way it's going to work. And she's handing it not to a physician, but to a pharmacist, and says, do something good with this so I have the right drug for me. When Francis Collins became director of NIH, he was interviewed by the New England Journal of Medicine. He had lots to say about a lot of things, and one of the things he talked about was pharmacogenomics. This is the entire quote, and basically he said, you know, if everyone's DNA sequence is already in their medical record, and it's simply a click of a mouse to find out all the relevant information, good things will happen, and at the bottom, the good things are improve outcomes and reduce adverse events. And I agree with that statement completely, except for this one word, which is, I can assure you, it's anything but simple. This is a picture of the Vanderbilt not electronic medical record room in the mid-1990s. We started to introduce an electronic record in the early 1990s, and by 2000, 2002 or so, that was the last time I held a manila folder in clinic. So when I go to clinic, it's all electronic. So the things that electronic records can do for you, and I recognize that there are people perhaps in this room, but certainly people in the community who feel that electronic medical records are being forced on them, and they're not really as good as they claim to be. But I really firmly believe that these are the things that electronic records can do for us. They can improve the care of individual patients. They can find specific subsets of patients with disease for either research or quality improvement purposes. They can discover new genotype-phenotype and phenotype-genotype relations. I'll tell you a little bit about that. They can be helpful in drug development and drug repurposing, and Ron Carden talked a little bit about that, and I may get to a little bit of that in my talk, but you can ask me a question afterwards if I don't, and then they're indispensable in terms of delivering genomic information to a practitioner and a patient in a care environment. So if you believe in this vision, who are the first people who are going to put a toe in the water to start to think about how to actually execute on something like this? And the way we think about it is that you have to be in a place which has a lot of expertise in the translational science around this, particularly in the clinical pharmacogenetics and the clinical pharmacology. You have to be in a place that, yes, I'm not doing that. You have to be in a place that has advanced information technology, has an electronic medical record that is mineable and that people are comfortable using. And then what you can do is you can harness the healthcare system for discovery, and I'll talk a little bit about that. And then once you make discoveries, you or the community, you can embed those discoveries into the electronic medical record. You can actually deliver information to physicians and patients, and good things will happen, we think. And one of the good things is discovery that feeds back to basic mechanisms. Now, we think Vanderbilt is a place where this can be done first, because we have all those things, including an institutional commitment to the idea. But I must say, giving this talk here makes me feel like this is a coal pile in Newcastle. So I feel like the Mayo Clinic is another place that obviously has the kind of institutional support and expertise in the basic sciences and the informatics sciences. So there's a number of institutions around the country. This is one, we're another, that are developing programs in this area. And I think we'll see, we're learning how to do it and how not to do it. So let me start by talking a little bit about discovery. So the resource that we've created to do discovery is something that we call BioView. So we have an electronic medical record that includes over 2 million patients. And what we've done as a first step is to create an image of that electronic record that we use for research that has identifiers stripped out of it. So it's a de-identified image. It's continuously updated. So we can use that. And that is a tool all by itself without worrying about any other omics aside from phenomics, the phenome. So then we have a subset of those patients have DNA samples. And the current subset is almost 190,000 of those. And I would love to tell you that they've all had full human genome sequences so we could actually play in that sandbox. But we have GWAS level data in about 20,000, and we have exome chip data in about 42,000 of those. So those are the resources that we have been using for the discovery efforts that I'll outline for you. The other thing that we have done is we have put the synthetic derivative on a high-speed search engine. So in the time it takes me to show the next 5 or 6 slides is the time it would take me to do a search in my office. So I can go to an interface without any IRB permission, because all I'm doing is asking the record, how many records do we have with these particular characteristics? So this is the interface. The particular example, I think, I have to go closer to see my slides, it was atrial fibrillation. So the question is, how many patients do we have with atrial fibrillation? If you don't know the ICD-9 codes, there's an easy way of finding them. You drag and drop them across. And it turns out we have, in the electronic medical record, the denominator is 2 million, about 45 or 46,000 people with atrial fibrillation codes. And then you can click a little button, and you can see how many of those have DNA samples, and it's about 10,000, 11,000 of those have DNA samples. And then you can actually ask the question, how many of them have genotypes that are interesting to you? So in this particular example, I've used the exome chip, and that, at the time this slide was made, we had about 34,000 people with exome chips. So the intersection of those two is 4,310. So we have 4,310 people who have exome chip data and diagnosis for atrial fibrillation. And if I want to, I can find out, I can click more where it says more charts on there, and I can find out how many are men, how many are women, how many are white, how many are African American, and information that's important for grant purposes. So we can do that, and that's a tool that our investigators use just to ask the question, do I have enough? Is there something in here that it can actually be a study? And then once they establish that they have a study, then there's a little bit of paperwork they have to go to get to the samples or to get to existing genotype data. Every time somebody gets genotyped in our biobank, the genotype data come back to us, so we reuse them over and over again. And at some point, we're going to end up with a set of enough people genotyped that people will never have to spend another dime on extra genotyping. We're not there yet. So one of the first things we did was ask ourselves the question, does this work? Can you actually find associations that you expect to find? This is like a positive control experiment. So we did the experiment that's outlined in this slide. We selected a bunch of common diagnoses that had reproducible SNP associations, and then developed methods to find cases and controls. And we did this experiment after we had 10,000 people in the biobank. And we focused on 5 diseases that are shown here. We developed algorithms to find cases and controls, and the algorithms are actually pretty complicated because you develop an algorithm, you deploy it, you ask the question, does it work? That means somebody goes through those cases by hand, and then if it doesn't work, we ask, why doesn't it work? And once we know that it works with a positive predictive value of 95%, we say we have an algorithm that finds atrial fibrillation, or finds rheumatoid arthritis, or finds type 2 diabetes, and then we deploy it. And we deploy it across our biobank, and on this slide, I also allude to the idea that we deploy it across eMERGE, which I'm going to talk about in a little bit. So as an example, in rheumatoid arthritis, in the first 10,000 cases, we had 255 definite cases of rheumatoid arthritis, 1,184 definite no's, and then there's a bunch of people in the middle who we don't know about. Mostly we ignore. The possible cases turn out to be mostly rheumatoid arthritis, but would require a lot of hand curation. And then there's a bunch of people in the middle. Now, we did this for 5 diseases. So sometimes a person is a case for one thing and a control for another thing. Sometimes a person is a case for 2 things. So that's the advantage of doing this in a multiplexed kind of way. And the SNPs we did, we also did them on all 10,000 people. We didn't wait around and figure out who was a case and control and then just genotype them for whatever it is that they were a case and control for. We just genotyped everybody. And it turns out to be cheaper and more efficient to do things that way as well. So this is the results. There are 21 SNPs on this slide. The red squares are the expected odds ratios from the literature. And what we found was that when we were powered, we reproduced the expected directionality of the SNP, and we reproduced it statistically significantly when the odds ratio starting out was about 1.4 or greater. So the point is, and every one of the point estimates goes in the right direction. So the point is that you can use a biobank like the one we built to actually make new discoveries. And we know that because this is with 10,000 people, and now we're at 190,000 people, so we're not replicating what other people have done anymore, we're making new discoveries. So you've seen this slide before, actually. Lon Cardin showed this, and this is the holy grail of anybody who wants to do pharmacogenomics in a large population. You find a small number of exotic cases. It doesn't take very many controls, and you can see that there's a striking signal for HLA toxicity for this particular drug and drug-induced liver injury. We've taken the biobank and started to do ask the same questions about drug efficacy and about drug toxicity. We have a large project that's ongoing that's looking at that with genotype data, and you can see 4 Manhattan plots here. And each one of them, sometimes there's a small number of cases, sometimes there's a large number of cases, and each one of them has a signal at genome-wide significance. And what I've learned by doing this is that the good news is that you have a signal. The bad news is that you have a signal because you're going to have to find somebody else who has the same kind of data and replicate. And it turns out not very many people have these kinds of data sets available. So the good news is we can do it. The bad news is we have to find people who will help us. One of the things that we've looked at is how long does it take to accumulate a cohort. This particular study, the VESPA project, looked at 30 different drug response phenotypes. And the question was, how long does it take you to accumulate a cohort of people with drug responses and controls, and how much does it cost? And we actually went back to the NIH reporter that lists grants that people have gotten to accumulate such cohorts, and compared the costs in time and money of accumulating cohorts in a prospective kind of one-off way versus this multiplexed way, and published those data earlier this year. And BioView is much faster and much cheaper, we think. So that's another advantage of a large data set, agnostically acquired, that you can actually start to identify people who are responding to cancer therapies, people who are responding to immune therapies, people who are responding to cardiovascular therapies, all in the same data set. We became part of the Electronic Medical Records and Genomics Network, eMERGE, when it was founded in 2007, 2008. Here are the sites. Mayo is on there, as you can see. And one of the things that we did, one of the first things we did was we asked the question, well, if you develop an algorithm at Vanderbilt, does it work at the Mayo Clinic? If you develop an algorithm at the Marshfield Clinic, does it work at Group Health and at the University of Washington? And these are data, I'm not sure that you can see them very well, but basically this is a phenotype that we all worked on together. It was hypothyroidism. And the hypothyroidism phenotype was developed at one place, our place, and then deployed across sites. And what's interesting here is that you can see that the positive predictive value for cases and for controls was really terrific. For the controls was terrific. For the cases was actually terrific at 4 of the 5 sites. Mayo was a little different, and without being facetious, Mayo has a catchment area that goes all the way around the world, and so it's conceivable that their unique patient population in some way affects that positive predictive value. But we were very, very happy that these cohorts that were acquired for different reasons, The Vanderbilt cohort was acquired because we were interested in conduction, and I'll show you that story in a second. The Mayo Clinic cohort was acquired because they had peripheral vascular disease, and there were cases and controls in that. But we were studying a completely different phenotype, reusing the data, and it works to deploy those algorithms. And eMERGE has created a website called the Phenotype Knowledge Base that posts all the logic around how to develop those algorithms and how well they work, because some of them can be pretty detailed. So let me tell you about the project that we did as our first eMERGE project. And when I'm not doing this, I'm a cardiac electrophysiologist, and I'm interested in abnormal rhythms. So what we did was we asked the question, can we find people in our electronic record who have totally normal electrocardiograms? They have normal ECGs, they have no heart disease, they have no drugs that can affect the ECG, they have normal electrolytes. Everything normal, normal, normal. And we found about 30,000 in our electronic medical record. And so the question we were asking is, why are some people at one end of the distribution, and why are other people at the other end of the distribution? So this is in 30,000 people. Not all of those had DNA. And so we did our genome-wide association study, and when we did our first genome-wide association study, we had no signal. Then we went and accumulated data from other eMERGE sites and got a larger data set. This is about 5,000 people, and we have a signal in chromosome 3 at a sodium channel locus that I could talk about for the next hour, but you probably don't want to hear that part of the story. So that was an interesting exercise. Other people had landed on this locus for this and related traits as well. But one of the things that we, did then was to ask a question that we hadn't been positioned to answer before, and that was to do a phenome scan. So let me introduce this idea. When you do a GWAS, or any kind of genetic association, what you do is you set up a phenotype and then ask the question, across many, many genotypes, which ones associate with that phenotype? We turned the question on its head and said, we have a genotype, a variant in a sodium channel, or a variant in a transcription factor, a variant in whatever you like. With what phenotype across the electronic medical record does that associate? We display the data in the same way, a Manhattan plot kind of thing, only now the abscissa is diagnosis codes, not chromosomal location. And to do this kind of experiment, what you need is lots of people with genotypes, and lots and lots and lots of important medical diagnoses that are made in them, and lots and lots of not medical diagnoses. So this is something that the electronic medical record is well suited for. I'm tempted to say uniquely suited for, but it's well suited for. So this is what we did. We did a phenome-wide association. This is one of the first ones we did. And when we did the phenome-wide association study, using as input the top SNP in our GWAS, we got 2 SNPs that had p-values of 10 to the minus third. That's not very impressive, but you don't pay much of a penalty for multiple comparisons, or not as much for this as you do in a GWAS. And what was interesting is that those 2 were arrhythmia phenotypes. And you sort of say, well, he's an arrhythmia guy, and so he's done an arrhythmia phenotype, and it's not a big surprise. But remember, we started with normal ECGs. So how do you end up with an atrial fibrillation code? And we sent this in, and the reviewers said, if this is true, then you ought to be able to go back to the data sets and figure out who has atrial fibrillation and who doesn't as a function of this genotype. So we did that. And there is, in fact, a gene-dose relationship between the genotype at that particular SNP and the development of atrial fibrillation. And what's really cool about this particular slide is the idea that the x-axis goes over 20 years. So that's something that electronic records can do. You've seen this before. This is the GWAS catalog. And so what we said, now that we know how to do phenome-wide scanning, let's take every hit in the GWAS catalog and ask the question, can we reproduce that particular genetic association? And some of these don't lend themselves very well to things that are in the electronic medical record. So there's GWAS, for example, on hair color, or there's GWAS on whether your urine smells after you eat asparagus. And those are things that are not captured in the medical record very well, or not at all. So of the ones that were captured, there are some that are repeatedly associated, so those are good associations. And basically, 2/3 of the well-powered associations were replicated in a set of only 13,000 people drawn from across eMERGE. And all those data are posted publicly, because that's what we do. And the person who did that wrote it up and got a paper in Nature Biotechnology, but got a paper that was much more important in the other kind of medical media, and that's the New York Times. There was this story about Josh Denny, and Josh is the person who has invented the phenome scanning technique and has pioneered the sort of further development of it at our place and across eMERGE. And this is an example of one of the things that happens when you do PheWAS. This is a PheWAS of IRF4 SNP that has been associated with hair color and eye color. And when we did the PheWAS, we draw striking associations with p-values of 10 to the minus 12, 14, 16 with skin diseases, specifically non-melanoma skin cancers and with actinic keratosis. So we think those are real associations, and in fact, other people have reported them using GWAS approaches since. I want to tell you a story which you may or may not be familiar with. This is a common SNP in a gene called APOL1. And there are variants in APOL1. There are actually variants that are linked, so there are linked haplotypes. That G1 and G2 are the variants that have a couple of linked SNPs with each other. And what's interesting is that those are pretty common, those variants in West Africa. And there's a story that suggests that these variants confer protection against sleeping sickness. Now, many African Americans, almost all African Americans, have their origins in West Africa. And so this is a common allele in the African American population. It doesn't exist, or almost doesn't exist, in the Caucasian population. And what's interesting is that while we don't have sleeping sickness in this country, what we do have is a huge burden of hypertension. And it turns out these variants predict the development of kidney disease in African Americans with hypertension. So a small number of SNPs. And the point of showing you this story is to say that if we're going to do genomics on scale, what we have to do is do it in many, many ancestries, because you do scientific discovery across the spectrum of people who have variants. And you've heard the story before. There are variants. The TPMT variant does not exist in the Asian population. This is a variant that exists only in certain parts of Africa. So you have to do genomics on scale if you're going to enable discovery, let alone enable everybody to benefit from what we learn about genomics. This is a PheWAS that we've done on those variants in APOL1. And what you can see is that we see striking signals with kidney disease, with kidney transplant, with going on dialysis. And actually, one of them is associated with abnormalities of dentition. And we're not sure that that's a signal yet, because the numbers are pretty small, but that's an interesting twist on that. So let me tell you another part of the story that I think is where this is going to go. These are data on the QT interval in 33,000 people in our biobank. And if you want to ask the question, what is it that accounts for people being in one part of that distribution compared to another, you would do a GWAS and you'd get a result that looks something like this. On the other hand, when I'm in my clinic, I occasionally see people who have really exotic phenotypes. So this is an actual ECG from a patient who has a QT interval of 900 milliseconds. And you can see on the abscissa on the top panel, 900 milliseconds is way out there. That's 100 standard deviations away from the mean. This is a genetic disease. It turns out to be an autosomal recessive disease. So this particular patient, actually both her parents have a single copy, a single abnormal allele, and she's unfortunate enough to get 2 of them. So you've seen this kind of plot before. The idea is relating allele frequencies to effect sizes. So the patient who I showed you is really, really exotic. She has a huge effect size. The effect size is 1 million or something like that. But the alleles are really, really rare. On the other hand, when you start to do genome-wide association, you're talking about alleles that are quite common and in general have very small effect sizes. And where I think the sweet spot is becoming is this middle ground, where we're looking at combinations of alleles, rare and common variants. We're looking at rare variants, not so rare that they only occur one time in 1 million, but rare enough that in order to find 100 cases, you have to draw from a denominator of 50,000 or something like that. And some of those have large effect sizes, I'll show you in a second. And then common variants and the environment together. And that's just a code word for saying pharmacogenetics, right? So common variants plus a drug can produce a phenotype that has pretty big effect sizes. This is a patient with Stevens-Johnson syndrome, and this happens to be a carbamazepine patient, I think, but this is with carbamazepine or abacavir, and the odds ratios that you get with these rare variants plus a drug can be in the hundreds. So these are obviously rare alleles that are highly actionable. This is a study that we participated in that was directed by Russ Altman, and basically he had a variant that he thought predisposed to deep venous thrombosis in African Americans. So how do you find African Americans with and without deep venous thrombosis? You go to BioView. And we contributed about half the subjects in this study. And you can see there's a rare variant, and it's much more common in patients with the DVT than controls, with an odds ratio of about 4 or 5. So that's getting pretty respectable. But in order to get this, you have to have large denominators to draw from. So this is what eMERGE looks like right now. There are approximately 350,000 patients with DNA samples across the network, and about 50,000 of them have genome-wide association data. And the point of showing this is to make the point that if we're going to move genetics into the sort of next era, we have to have these large numbers to personalize. If you want to treat one patient out of 100 differently from all the rest, the way you have to do that is to not study 100 patients, but you have to study 100,000 patients to identify that small subset of 1,000 that are different enough from the rest that you can, with a straight face, treat them quite differently. So extreme phenotypes, that could be extreme drug reactions, good drug reactions, or bad drug reactions, rare genetic variants with large effect sizes. And then we think that, remember, all the PheWAS data I've shown you has been with 13,000 people with GWAS data. If we had 100,000 people with GWAS data, we would be in a much better position to make discoveries with this approach as opposed to validation. And I think I'll skip that. So in the last 8 minutes and 9 seconds, I'm going to talk to you a little bit about our efforts in implementation. So now that we know something about some variants that we think are important enough to implement, what should we do with them? So this is simply a click of the mouse again. And our project is called PREDICT. And PREDICT stands for the things that you see up there. I can never remember what PREDICT stands for, so I'm not even going to read it to you. So the notion that we had in 2009, when I was tasked by our leadership to come up with something along these lines, was select a population of patients who were at high risk for getting a drug with an actionable pharmacogenetic story of the type that Larry Lesko talked to you about. And we were thinking about what might mean. And then we would genotype people who we identified as at risk, not for the SNP that related to the drug that got them into our attention, but for a series of variants that are important for drug responses across the board. And then we would store the genotypes, track outcomes, deliver information at the point of care, all that stuff. So we're sitting around thinking about what we should do, and then Larry and his buddies at the FDA did us a favor because they relabeled Clopidogrel. They didn't say you should genetically test people, but they said if you happen to have genetic information, then you should act on it in this particular way. Consider alternate treatment or treatment strategies. So we sort of jumped on that. Now let me just go back and make a point. And that is, these are data from a French investigator named Sébastien Hulot. And in 2006, he was interested in Clopidogrel. And we knew that Clopidogrel was a prodrug, but the pathway by which it was bioactivated was uncertain. And he took patients who were CYP2C19 wild type and CYP2C19 star 1, star 2. That means they carry one copy, one loss of function copy of the CYP2C19 gene, and studied platelet reactivity at baseline. And there's no difference between the two groups, as you can see. But after 7 days of 75 milligrams of Clopidogrel a day, there was a striking decrease in platelet reactivity among the wild-type patients. So they were exposed to the active drug, because Clopidogrel was bioactivated in them, and no change or very little change in the CYP2C19 star 1, star 2s. And I show this because you can see that when you plot data for individual subjects, some of them have a response and some of them don't, in both groups. But when you look at means, the mean of the people with the variant didn't change. So that's the evidence that we have. And the question that you end up asking yourself, and then that translates into a lower, or into a higher risk for complications during Clopidogrel therapy because the drug is not as effective as it should be. This is the effect size that you're looking at. You're not looking at all or none. You're looking at shades of gray, and I'll come back to that in a moment. So what is actionable? Is the APOL1 variant story actionable enough? We think the HLA story around abacavir certainly is actionable, and people debate about Clopidogrel. And our contention is if you know about Clopidogrel variants, you should use them. The question is, where's the cost effectiveness, all those other questions that people ask, and we think our model of multiplex genotyping can get at some of that. I never know whether I should show this slide or not. Some people think it's inappropriate, but I'm going to tell you anyway, and that's that this reflects the idea that people have an expectation that genetics is going to give them an answer that is black or white. I want to know, this SNP is going to tell me, do this or do that. And that's not the way it works. Clopidogrel just shades the odds. It's not black and white. It's all about 50 shades of gray. See? I haven't read that book. I just have to tell you that. So time passes, and this is what the electronic medical record at Vanderbilt looks like right now. This is one of my patients. All the identifying information is stripped out except my name, just to make sure that you know it's my patient. And we deliver information on Clopidogrel and warfarin and TPMT and tacrolimus in this particular example. And when a patient who has variant genetics is prescribed Clopidogrel, the system fires, and it fires this long decision support that says genetic testing has been carried out. Your patient may be at increased risk for having an unusual or bad effect. So that's what we do right now. In our first 13,000 people, 2.7% had 2 copies of the loss of functional allele. Those are the ones you want to go after. 19% were heterozygotes, so they'll have reduced effects, but it may not be reduced enough that you can see it in the noise that is the healthcare system. And most people have no variant. So if you prospectively genotype people, every time they start Clopidogrel, you're going to do a lot of genotyping for not very much gain. But now we're up to 5 drug gene pairs now, and this is what happens with each of the drug gene pairs. There's a small number of people who have variant genetics that are really important, another group of people who have variant genetics that are a little bit important, we think, if you're a passionate advocate of this approach, and then a bunch of people who are normal. But when you add them up, after 5 drug gene pairs, almost everybody has something. And so the point I make to audiences like this is, everybody has something. You just don't know what it is. And so if you're going to do this, the way I think to do it is to preemptively genotype everybody or every selected patient for variants that may affect commonly used drugs all at once. And so that's the approach, that's the philosophy underlying PREDICT, and this is one piece of evidence that supports that approach. So one of the last issues is how are we going to educate healthcare providers? So Dick Winchelbaum invited me to come to this meeting, and I said I would be happy to. And that's one of the things that I sort of feel is part of my mission in life. And I've actually organized a Coursera course. This is one of these online courses, and it's about to go online. And this is a picture of one of the things where I'm trying to explain how do you do prediction and do receiver operating curves. So there's the website. It'll eventually be online, and some of the information that you heard about today will be transmitted in that way. So let me just quickly summarize what I've said. Phenotypic information in electronic medical records can be used for discovery. I think there's also this unprecedented opportunity to understand basic mechanisms. I gave you a little bit of a vignette about the sodium channel story. A great question is, how does that all work? And every time we come up with a new variant, TRAN5, you heard about from Dick Winchelbaum, you have to ask yourself, well, how does that work? What are the mechanisms? And so I think that this is a terrific window into new mechanisms. Delivering low-hanging fruit, even in the pharmacogenomic space, where we think we understand some of this, is very complicated. You have to have great assays. You have to assay more than one common allele. There's issues around ancestry, so we've spent a huge amount of time studying CYP2C9, 2C9, STAR2, and STAR3, which are great if you're Caucasian, but if you're African American, those are irrelevant. What you want to do is do STAR6 and STAR8 and STAR11. And most studies haven't focused on those at all. So I think you have to expand ancestry in all of these studies, not just to deliver the information, but to also do discovery. The APOL1 story is part of that. And then there's a huge number of other needs that we have on the table. Educational needs, the need for very high quality genomic data if you're going to use it for actionability. There's this problem of a huge number of variants of uncertain significance, and I can talk a little bit more about that in the question period, but it turns out if you sequence lots and lots of genes, you'll find lots and lots of variants. We're all sewers that are full of genetic variation, most of which doesn't do anything to anybody. But if you found a variant in a cancer susceptibility gene, does that mean you're susceptible to cancer or not? And this is a problem that the community is going to have to grapple with. If we're going to deliver the information, I don't think we can do it in any way except using electronic medical records. I close with this slide that shows the very first patient that we had in the PREDICT program who was a CYP2C19 STAR2 carrier. She had had a stent put in by her cardiologist, who's shown in this picture as well. And what I say is that this is all about personalizing medicine. So he takes care of her. She has other diseases, she has other conditions, she takes other medications, and now he knows a little bit more about what might work and what won't work in her. So it's about shading the odds that the outcome will be better by personalizing, but he knows about her, so it's a personal relationship. And I'll just close by showing a picture of the big teams that we have deployed at Vanderbilt, and this is part of the teams that have accomplished some of the work that I've shown you, and hopefully will continue to show you. Thank you very much.
Thank you, Dr. Roden.
Great.
Several questions have come in, so I'm going to do a little lightning round so we can feed everybody. First one, though, from the audience, asking you to talk a little bit more about the challenges in doing both whole exome and whole genome sequencing when you're trying to implement it into the electronic medical record.
I don't think whole exome or whole genome is going to be part of the electronic medical record anytime soon. There's this vision that you're going to have your entire genome sitting in an electronic repository somewhere and accessible to you and your doctor. And I think we've discovered that the whole exomes are pretty complicated places. And so the way I think about it, and I think it's a pretty commonly held vision, is that when you have your data analyzed, and it has to be, again, very high quality, it'll sit in a repository somewhere else. It won't sit in the electronic record. And then as we discover things that are important for your care, we'll pull those out and stick them in the electronic record. So if I do, a very almost trivial example is when we do the PREDICT genotyping, we genotype for about 180 SNPs. But we go through an exercise at our place that decides which of those variants are important for predicting response to particular drugs. And we actually only have implemented a very small fraction of those. So even on a platform that was developed to predict variable drug responses, we use only a very small minority of that information. The rest of it sits in a repository. If we need to, we can pull it out. So if we decide that we have to have a variant and a transporter, we can say, well, that evidence is strong enough, we develop the decision support, and then we immediately populate 13,000 or 14,000 records with that information, because it's sitting there, but it's not good enough to deploy. And we don't think we want to start to muddy the electronic record with stuff that we don't know how to interpret. So that's the way I think it'll work.
Another question relating to Vanderbilt's EMR system, and it says that Vanderbilt apparently has progressed so far in PheWAS since it wrote its own electronic medical record system. What's the difference between the Vanderbilt system and perhaps some of the other institutions that maybe came later, but...
Right. Well, so we work with eMERGE, and we have collaborations with people who have Epic systems, with people who have Cerner systems, and the trick is to get the genetic information coupled to the phenotypic information, and one of the things that we've spent a lot of time working on is getting the phenotypes right. So the very first phenotypes were ICD-9 codes. You know, do you have rheumatoid arthritis? Yes or no? And if you had a code for lupus, we wouldn't consider you a case of rheumatoid arthritis, but we wouldn't consider you a control either. So you have to sort of do a little bit of curating of the phenotypes. But our hope is that we'll be able to get the phenotypes much more densely organized, so that we'll go into the actual text and we'll create not phenotypes of rheumatoid arthritis, but subphenotypes, this kind of rheumatoid arthritis that has this drug response and has this biomarker and is likely to progress to this kind of deforming arthritis unless this particular medicine is used. So the hope is that by using phenome scanning, coupling to genomic and other omic markers, we'll be able to create subcategories of disease, and so it's enabling for the research, but it's also enabling for care.
It seems to me whenever we have conversations around electronic medical records and data, we always end up at the question, who owns it or who should own it?
Well, so I don't have a good answer for that. As a consumer of healthcare, I feel like whatever is in my electronic medical record, I certainly need to have access to. Now, I consider myself a relatively sophisticated consumer of healthcare, so I don't mind going into my own EMR and reading what people write about me or interpreting my lab data. When my wife gets her lab data, she always asks me, well, what does this particular lab test mean that's abnormal? And it's usually just some junk that is meaningless. But if you're a civilian, I despair of what happens if civilians get hold of the electronic record, not because of the stupid things that people write in there, but there's a huge amount of very difficult to interpret information. So one of the challenges that we as a profession face is this idea of transmitting to patients who had not gone to medical school what's important, what's not. And I do think that people have ownership of their own healthcare information, but what I don't want to do is inflict all that on people so that all it creates is anxieties. And it's sort of like, here's your whole genome, and you know, that SNP carries a 10% increased risk of cancer in some studies. And
right, so that
what we don't want to do
about...
is create a generation of people who are worried about a huge amount of stuff and who then start to put demands on the healthcare system to do a lot of screening that is inappropriate.
Sure, yeah, good point. And I think this question follows on nicely to that, and the person is asking about whether or not all of this information and the availability of the EMR might affect getting a second and third opinion. Could it potentially influence those physicians who might be seeing the earlier opinions?
Sure, you know, but people who end up, if you're in the position of being the provider of a second opinion, then you know one of your jobs is to accumulate as much information as you can about the patient and their disease, and part of that is what other people thought. But if you're a good provider of a second opinion, you also sort of take all that with a grain of salt, and you say, well, you know, let me start from the beginning and let me not pay attention to what this other doctor said. Let me just try to approach it dispassionately. So actually, I think you know, if you have electronic records, you can actually deliver all that information and let somebody go through it and see what people's thought processes were. And sometimes you agree with them, sometimes you don't. But presumably, as a second opinion provider, you shouldn't be biased by what other people have said, because your job is to look at it dispassionately.
It's really more information at their fingertips.
That's right.
Mm-hmm. Another great one along this same theme as well. So as more and more of this information is landing in the electronic medical record, is there any potential risk of that affecting, for instance, an individual's ability to get a disability insurance or long-term or life insurance? I mean, we know now health insurance that can't occur because of the law, but what about some of those others?
So the law is imperfect. There's no question about that, because the law allows discrimination, or doesn't forbid discrimination. It doesn't say anything about discrimination on the basis of long-term care or disability. So one of the things that we face, for example, when I'm wearing my arrhythmia hat, so I'll see patients in my clinic who come from families where there may have been a teenager who died suddenly from one of these ion channel diseases that I study, and then you actually can find the variant that caused that or was associated with that, and then you ask everybody in the family wants to be tested, and you have to point out to them if you get tested, and then you're getting insurance, they will ask you, were you ever tested, and what was the result, and they might deny you a long-term care or disability insurance based on that. Now, the problem is that not much has changed in the last 20 years in the sense that 20 years ago they should have asked you, does anybody in your family die suddenly? And that would be that's as good a genetic test as any other. Or in some ways, it's as good as any other. So the idea of discriminating against people based on genetic information has sort of always been there, but now that we have a specific genetic test that we can do, it's sort of focused people's attention. And I think that it is a problem. So we actually tell patients sometimes that, you may not want to do that because you will be denied insurance. And then there's these stories about people who say, well, I'm going to get myself tested for Huntington's disease, but before I do that, I'm going to go out and get long-term insurance. And then I'll get myself tested. And of course, the argument then is, well, if you're the long-term insurance provider, maybe you should ask what their father died of and figure it out for yourself. Right. But they don't tend to be that sophisticated yet. No. So, as I said before, every single one of us has lots and lots of variants that would terrify you if you knew about them and probably have nothing to do with your care. And that's one of the big challenges of contemporary genetics and pharmacogenetics, to sort through all that.
Yeah, but really the value of something as simple as the family history can be so powerful. I've seen it myself. In your presentation, you did talk about using genetic databases to ID drug targets. Can you elaborate a little more on how we might see that happening?
So there are a couple. There's the poster child for this is a gene called PCSK9. A very distinguished lipid investigator named Helen Hobbs at UT Southwestern knew about PCSK9 and its pivotal role in controlling LDL cholesterol from cellular experiments and small numbers of experiments in people. And what she did at a time when genotyping was much, much harder than it is now, using old-style genotyping, she said, let me take 3,500 middle-aged African Americans who live in Dallas and sequence the PCSK9 gene. So she sequenced them, and that was a huge thing to do in the mid-2000s, and found 85 out of 3,500 who had stop codons in this gene. So that means that the protein will not be expressed in those 85, and they're all heterozygotes. And then she asked the question, what happens to their LDL cholesterol? And their LDL cholesterols were much lower than anybody else's. The controls. And then she said, well, what about the development of coronary disease? Because these are middle-aged patients who have been exquisitely phenotyped for coronary disease, and it turned out their incidence of coronary disease was really, really low, 90% lower than the control group. So what that says is you're missing PCSK9 all your life, and the only phenotype you can find is a lower LDL cholesterol and less coronary disease. Well, if I were a drug company, I'd say, well, let me find a drug that can inhibit PCSK9 function. And the time between Helen Hobbs' initial report in the New England Journal and the first report in the New England Journal describing what happens when you inject an antibody against PCSK9 in human beings, what happens to LDL cholesterol, was 6 years. And those drugs, which are, unfortunately, that turns out to be a protein that it's hard to drug. It's hard to find molecules that inhibit its function. So the current molecules that are available are antibodies that have to be infused. But those drugs are in phase 3 trials now. So the idea of using genetics to validate drug targets, to find new drug targets, there's a similar story around a gene called ApoC3. And again, loss of function variants in ApoC3 associated with much lower triglycerides. Now, when I grew up, everybody sort of said, well, higher triglycerides, lower triglycerides, does that does that affect coronary disease or not? So what we've shown, or what people have shown with ApoC3 variants, is that not only do they result in lifelong lowering of triglycerides, but much less coronary disease as well. So that validates triglycerides as a target, and it also suggests that ApoC3 can be targetable because it's the same story. So there are these stories that come from genetics, and those are population genetics. There's one more story. There are these families that have children who don't feel pain. And you'd think that's a great thing, but of course, if you're an active 6-year-old and you jump out of a tree and break a leg and don't know it, those are bad things that happen. So those children actually tend to have terrible complications and even die from the lack of ability to perceive pain. But it turns out that the genetics of that are loss of function in a particular sodium channel that's important for transmitting pain to the head. And if you had a drug that inhibits that sodium channel, you might have a terrific analgesic. So the lessons from genetics in terms of finding drug targets and validating drug targets, but what it's going to take is finding the unusual genetic variant and then asking what the phenotype is, or finding the unusual phenotype and then asking what the genetics are. So that's why you have to have the denominators of 100,000 or 1 million to do that rather than 10,000.
Right. Well, yesterday we had a fun little conversation about gold digger wives and biomarkers, so I was very tempted to ask about 50 Shades of Grey. But I think we're going to have to save that for the lunch table discussion. Okay. Let's thank Dr. Dan Roden.
Thank you.